Lovely. Okay. Welcome everybody to this little session on menopause and HRT. My name is Dragana Abbott and I work as a specialist nurse in menopause and benign gynecology. I've had a little composed PowerPoint slide, but I'm not going to really go too much on about the PowerPoint slides. I'm going to enable you to interact with me with questions and answers with regards to the menopause and HRT as we go along. I'll just briefly change the slides and just let you know that this will be as much as interactive session as you would like it to be. So let's start with the first slide. We can all appreciate a little bit of a humor in this slide. With everything in life, we are going through some big changes from the day we reach puberty and go through puberty, and then we have another big change when we are perimenopausal and we enter the menopause. It's very important to disseminate appropriate information and offer support that's evidence-based and in keeping with all of the research and the studies and the governing bodies of the British Menopause Society and the NICE guidelines. So we'll just briefly go through the phases of the menopause. Indy, if you can click on yes. So perimenopause, menopause, and then postmenopause. So when we are reaching postmenopause, and that is when we completely have our last period and cessation of our period and reproductive function, we are for the rest of our life in postmenopause. So that's a very big chunk of our period of life that we spent in postmenopause, and it's very essential that we develop very good healthy habits and understanding and knowledge by receiving a lot of information when it's like with regards to the menopause, because we in our life, in modern days, we live a very, very good, healthy amount of time, which could be sometimes even 40 years post-menopause. So it's very essential that we're equipped with the right information and the right knowledge in order to make informed choices and decisions when it comes down to our health, our well-being, the use of HRT during our perimenopause, menopause, and postmenopause, or even a non-use of HRT. It's all on individual basis. Indy, if we would like to go through the next slides very quickly. Early menopause and age. The premature menopause is when a woman reaches menopause before 40, and then early menopause when a woman reaches menopause before she is 45. So there are many different individuals that are experiencing the premature menopause or early menopause, or even sometimes post-cancer treatment and post-hysterectomy and bilateral salpingo-oophorectomy. So we just need to raise awareness that there are many different scenarios how a woman can enter either a perimenopause or premature menopause and have the effects of this in her life. If we move to the next slide, please. This is just another little humor, but there are more symptoms of the menopause, and in fact there are more than 40 symptoms of the menopause, and we are still adding more to it, and us as women, we are going to experience even in our perimenopause certain symptoms that are derived from the lack of estrogen in our body, the estrogen production, and then it's going to affect us in many different ways. And especially in the perimenopause, we can have peaks and troughs of the estrogen production, and that can affect us even like for 10 years before we actually reach menopause. If we move to the next slide, please. These are some of the main symptoms that we are like more aware, but all other symptoms are not to be excluded from this list. So first of all is the vasomotor symptoms that everybody notices, but not all women will have the vasomotor symptoms. Then it's our genitourinary symptoms of the menopause due to the lack of estrogen, and then musculoskeletal, and then physiological as well. If we go to the next slide, please. It's all to do about diagnosing the menopause, which we look into it more with the general practitioners and the primary care, and then everything links up to us in secondary care. If we move to the next slide, please. So consequences of the menopause. So this is the most important. So the lack of estrogen in our body, or the declining levels of estrogen, has proven that it affects our bones, and we are at risk of developing osteopenia and osteoporosis, and again increased risk of the cardiovascular disease and cerebrovascular accidents. With the atrophic changes that happen to our vaginal and vulval health, and also urogyny issues that are related specifically to the estrogen decline. So now this is even more pronounced in women who are going through menopause a lot earlier than the average age of the menopause at 51. So we need to be more aware that there are special risks that are actually even more pronounced when a woman is in menopause below 40, that we find, or early menopause between the ages of 40 and 45. Please, if we can have the next slide. So management, there is always the non-hormonal ways for managing the menopause, as you can see here on the slide. But this talk is specifically designed for like menopause and HRT, which we can go on to the next slide, please. So the benefits of HRT, as you can see mentioned here, are those, but it's like it comes with risks, and the risks are only when we are taking in consideration a woman taking HRT for 5 years and it's over the age of 51. So the women who are on HRT who have entered earlier menopause or premature menopause, the risks are just exactly the same as with the general population who are not even on HRT. It's just only the combination of 5 years when a woman is taking HRT from the age of 51 for 5 years or later, because of the study that has been done between women of 51 years of age and 59 years of age. If we move to the next slide, please. So this is the study that I have talked about. So this has taken in consideration women who were from the normal age of menopause in the UK from the age of 51 to 59, and they've looked into 5 years of use of HRT and what is actually the risk of breast cancer. So as you can see, that out of 1,000 women, and this is the 1,000 women study. So out of the 1,000 women, 23 cases have been just diagnosed of breast cancer in the general population. So an additional only 4 cases to the 23 cases have been found that are women taking the combined HRT replacement therapy. So now there is a question of saying, does HRT causes breast cancer? And the answer that is there by the research is not really per se that the HRT causes the breast cancer, but what it does happen to when the individual is taking for 5 years HRT, combined HRT, is that the HRT accelerates the breast cancer that could have happened at a later date. So because of various different health and life choices, health conditions, comorbidities, we don't know what exact comorbidities all these women had and what has been happening at that particular time, that they had 4 extra cases of breast cancer. But what has been found is that taking HRT, and if somebody has predisposition or any genetic predisposition towards developing of breast cancer, the acceleration of the breast cancer will be very, very quick when we are using HRT. So now, interestingly enough, 4 fewer cases of women have been found that have had breast cancer just using only estrogen hormone replacement therapy. And those are the women who have had hysterectomies. So now, if you can scroll down all the way to the body mass index that's equal or greater than 30, you can see how much more and how many more women have been diagnosed with breast cancer. So just to put all in perspective, is multiple lifestyle choices, multiple things that we need to take in consideration when we're thinking and debating, is it okay for us to be taking HRT, how safe it is, and what are the risks of breast cancer. Next slide, please. So the estrogen deficiency, and in somebody who is not taking HRT, and in most women who are not on HRT, over the period of time when we are postmenopausal, the estrogen deficiency will ultimately lead to osteopenia and osteoporosis. Because as you can see, the estrogen has a very, very complex role on our bone health. And if we move to the next slide, please. We need to, let me just have a little look, something just popped on my screen. So we need to take in consideration that we need to disseminate information that HRT can in fact help with bone health and cardiovascular health. And we just need to make sure that women are aware of the certain risks that HRT has, and an individual person should be counseled, advised, and a really good assessment done when we're starting with the correct HRT. And this starting of HRT can be done by your GP in primary care, and everybody should have this chart and like operate with all of this and tailor the whole correct treatment of HRT with every woman and every individual. And every individual has to have the autonomy to decide what is best for them, because not every woman would like to or would want to be taking HRT. So when the decision is made with the patient or with the individual themselves to actually take HRT, we need to then come to what is the correct option for each individual and what is the correct HRT to take. Next slide, please. I don't want to, there is like loads of things that I can be telling you, but I just want to have a little bit more of interaction and questions and answers. So this is another little bit of a humor, and especially in primary care, because we've all heard patients even going to the GPs and saying like, yes, these are my symptoms, this is what's happening with me, and people have come back and patients have come back to myself saying that the symptoms are not really taken seriously. So I just wanted to throw in a little humor. If we move to the next slide. So HRT, yeah, thank you. With the HRT, it's not only systemic HRT, but we need to be thinking about having the topical estrogen, which is vaginal and vulval estrogen, that helps with genitourinary symptoms of the menopause. And this does not add to the systemic HRT that we're already taking. So when we're treating a patient or a woman who is going through the menopause and has some genitourinary symptoms, it's always good to ask and ascertain, is there any other symptoms that she's experiencing and how everything feels, and to the individual, and whether they are having any even increased UTIs or vaginal dryness or any other sexual issues that are associated, including low libido. And then it's very good and very nice practice to have all of that in mind, so we can counsel women with all of the topical estrogens that they can have and that are out there on prescription on the NHS, and they can be obtained through the GP. Next slide, please. Again, many different systemic HRT treatments, depending whether a woman has a womb or has had a hysterectomy. So there are oral HRT, there are transdermal HRT, there are spray estrogen in combination with micronized progesterone. So many different types of HRT are out there for patients' use. If we go to the next slide, and the HRT guide and review, when to refer to secondary care, I'll just let you just read through it. And if we move to the next slide, please. And this is the most important thing. So we need to ask every individual, and every individual has the right to make their own choice and decision when it comes down to HRT and their unique personal circumstances and symptoms, because we can, as we said, we can manage symptoms in many different ways. So we need to ask women, do they really want HRT? Are they informed about the risks and benefits? Are symptoms local or systemic? Is the patient perimenopausal or postmenopausal? Which types of estrogen or preparations, either they're oral or transdermal or spray? Which progesterone, because they're synthetic and then body identical? And are the women reviewed correctly? We can close the whole presentation. It's not a problem now. We can come out of it, and I would like to have some questions and answers, so you can turn your microphones on and ask or contribute towards this Teams meeting as you see fit. Hello? Can we have anybody?
Dragan, there's a question in the chat. Chat. Do you want to read that?
Okay, let me just come out. What to get tested hormone-wise when perimenopausal? How to interpret these tests? How do we define perimenopause when it comes to hormonal test results? When to consider HRT? What doses to consider, and how to start the HRT treatment? Who can prescribe it for me? And how do they make a decision if I need it? Okay, so when we're perimenopausal, the levels of LH and FSH will fluctuate. So it's not a really solid marker to rely on, because some months it can be different to another with the reading. So what we do and what we know, that everybody over the age of 40 would be slowly entering towards perimenopause, and perimenopause can last 10 years and even more than 10 years. So what the general practitioners in primary care are going on is based on symptoms. So if you're having menopausal symptoms, and if you're noticing that your periods are either getting shorter or longer in time, or the blood flow is different, you're suffering menopausal symptoms, then it's essential to report to your GP and explain exactly what is going on, so they can do like a baseline of tests, and then it can be considered to start HRT even when you're perimenopausal, but the HRT will come in very, very low doses, because we know that still the ovaries are still having a function, and at some months they can produce more estrogen, and some months there will be a decline. So it will be very beneficial to ascertain, just like a standard blood test with many different things tested, like the thyroid, full lipid profile, full blood count, vitamin D, vitamin B12, um, the FSH and LH should be also tested, and then a conversation held with the GP of what's the best way to approach it, and whether you can have like a small lower dose of HRT included. And HRT is not contraceptive, so we need to be thinking also using of contraception. But yes, definitely in perimenopause, if like we are experiencing some debilitating symptoms of the menopause, we can use HRT. Uh, I can the help website. So the question is, please could you show the help websites again? So on our Rosie website, on Rosie Hospital, there is a menopause web page that has got a lot of information and a lot of different links to various websites that are really beneficial and essential for us to read, which is really good. And one of them is definitely the British Menopause Society, Menopause Matters, and so on. Is the increased risk of breast cancer only present after 5 years of being on HRT, or does the risk increase the longer you're on HRT up to 5 years and beyond? So no. So they've done the study, and they've taken the 5 years of being on HRT, and they saw that there is the increased risk of breast cancer, which is the 4 women extra diagnosed with breast cancer. But the more you take the HRT, it actually accumulates 5 years and beyond. So that is very correct. So that's why we have the responsibility of care towards each patient to have very good and solid HRT reviews each year, and discuss the pros and the cons and the risks of taking it further, because if the quality of life is improved on HRT and the risks are small, we can still remain on HRT, and the woman can make a decision and choice whether to stay on the HRT. But if the risks are outweighing the benefits, then different decisions can be made together, joint with your primary care provider. When do you stop taking HRT? There are no arbitrary limits of taking HRT. So that is what the British Menopause Society has said. So if a woman, again, is entirely up to the individual to make a choice for how long she is willing or wanting to use the HRT to relieve and gain the benefits from it. So I've had patients even in their 80s still on HRT, and as long as we provide with the information of the risks and talk and counsel women, women can consent and make their own choice of what they wish to do in terms of HRT. So as long as the woman is aware of the risks and is aware of how everything is with like the accumulated time of taking HRT and what happens, she can still decide, okay, yes, the taking of the HRT benefits me and my personal circumstances, and I would like to continue with the HRT, or I would like to stop. Is a side effect of topical estrogen water retention, especially in the legs? No. The topical estrogen, I will give you an example. Most of you have heard of Vagifem, which is vaginal pessary that's inserted for 2 weeks every night into the vagina, and then maintenance dose is every 2 days in a week to just have like maintenance. So this is a topical estrogen. So if you imagine taking this topical estrogen every single day for a year, the equivalent dose in an oral preparation of estrogen will be 1 milligram of estrogen taken orally. It's that little and minimal. So it can't affect us in any water retention or any other body functions that happens to us. Another person is saying, my GP disregarded me, unfortunately, because I still have my periods. However, not as regular, and I also have the symptoms. Should I insist that my GP tests my estrogen levels at different intervals? Would this help for them to get more information and potentially prescribe the low dose HRT? No. Testing estrogen is not very reliable because 1 month it can be normal, another month can be low. We always should go by the symptoms and the approximate age of the person, and then run the blood tests as just like a base level to just check for any other things that are like just like a health check. Just imagine like you have to have the blood test done as part of your health check, and then you present with the symptoms, and they can definitely start you on a low dose of HRT, providing everything like it comes back like with all of the blood results, and everything is normal in terms of other things, and especially with the thyroid, because we do worry about the thyroid. And we then assess with the woman, especially with the menopausal symptoms that she is having, it's not unreasonable to be on HRT. I don't know how old you are, but I would definitely go back to your GP and ask them to do a health check blood test, check the FSH and the LH, explain what the symptoms are of an issue, and ask for HRT to be prescribed. And another way of actually dealing in a very gentle way with contraception and HRT in the perimenopause is by the use of Mirena coil, which is a contraceptive device, but it is also licensed as part of a progesterone part of HRT. So if somebody is suffering with very unscheduled bleedings and periods and very different things happening in terms of how you're experiencing the perimenopause, this can be an ideal way to balance like the progesterone and balance the endometrial lining. And then depending on your symptoms, you can be titrated with estrogen, a body identical estrogen added to the Mirena coil. And it could be only a small dose that makes a massive benefit and makes you feel a lot better in yourself and optimizes the quality of your life. Yes, another question, thank you very much. Is the coil considered a type of HRT? My GP has recommended this as a form of treatment for debilitating perimenopausal symptoms. Are there any elevated breast cancer risks associated with the coil? Now, I don't know the age of the person, so it's very difficult for me to say, but the risks of elevated breast cancer risk, it only happens when you're age of 51 and above. And it only happens, the increased risk is 5 years of use of combined HRT above the age of 51. But yes, the coil, the Mirena coil, can be used as the progesterone part of an HRT even in perimenopause, and it can actually be a very good way of stabilizing even heavier bleeds that sometimes we experience in perimenopause due to the fluctuation of the hormones. And then what we have in the perimenopause, sometimes there are like delayed periods because we have amenorrhea for a couple of months and we don't release an egg to ovulate. So what happens, our endometrium builds up, builds up, builds up, builds up, and then when we have a period, we have a heavy period and heavy bleed. So the Mirena can definitely help in managing the endometrial lining and keeping it thin, nice and thin. And it's a very slow release hormone of a synthetic progesterone, and then we can add the body identical estrogens. What levels of FSH and free T4 are classed as peri or menopause? I've had recent blood tests, currently on the pill, HRT patch Evorel 75 and Utrogestan 100, age 52. So because you're on HRT patch and the Utrogestan, testing the FSH and the LH will not be advised because it will be completely masked. But because of the age of 52, we know that the average age in the UK is 51 of reaching the menopause, but sometimes people can be a little bit later with their menopause. So the HRT with the patch, which is Evorel, and the body identical Utrogestan, which is the microgenized progesterone, is an adequate treatment. And I hope it is on continuous basis, but with the level of the 75 micrograms of Evorel, if you're having any unscheduled bleeding or any spotting on this regime, the Utrogestan has to be 200 to keep the endometrial lining thin, and it has to be taken orally at night before you go to sleep. So that's the only concern that I might have with the levels, because it has to be very well balanced with estrogen and in conjunction with how high the estrogen of the HRT is, so we can use the progesterone, and the progesterone is only used to keep the endometrial lining thin in HRT. So it has to be well balanced with what we are stimulating with the HRT that we're taking. We need to have the adequate cover of progesterone. Thank you. My family members entered full-on menopause before 40. Okay, so if a woman enters a very premature menopause and also an early menopause, it's of utmost necessity to go to the health providers and ask for bone scan, which is the DEXA scan, because we know that if we are exposed to very, very low estrogen very earlier on, we are at risk of developing very earlier on osteopenia and osteoporosis. And in order to avoid this, any woman who is diagnosed with premature menopause or very early menopause has to be on HRT in order to help her with bone loss and the risk of developing of osteoporosis, but also the risk, the very, very high risk that she will have of developing cardiovascular disease. And the longevity is affected by not having hormones when a woman should normally produce those hormones. So just treat it as supplementing, just like we supplement vitamin D. All women below the age of 45 who've entered really early menopause, they have to be taking HRT for their health. I'm on HRT, but I feel so tired all the time. Is my HRT working? Right. So we need to find out. You can go back to your GP because there are cases of women that are not able to absorb the estrogen either through patches, oral preparations. So we need to check the absorbency level. So I will give you one example of a woman's blood level of estradiol when they're on HRT should be between 250 to 600 to feel that the effects or the undesired symptoms that are associated with the menopause and all of the debilitating, even vasomotor or cognitive issues and complaints that we see in practice are alleviated. So if your level of estradiol while you're on HRT is below 250, you will still be experiencing symptoms. And also, we don't know what kind of preparation you're using, and the GP needs to, or if they can't deal with your particular case, they need to refer you towards us in secondary care so we can investigate and make sure that you are very well estrogenized on standard systemic HRT before we look into anything else, what's happening, because it could well be that you're not receiving enough estrogen. And it's not because you're not getting the dose of the HRT correct, it's because of the absorbency. And we don't know, like some people do not absorb estrogen very well towards like in different routes. So we need to find what's the best preparation for you to take in order to be well estrogenized on systemic HRT. Do symptoms experienced in perimenopause continue into postmenopause? Are they temporary or forever? Now, the answer is yes and no. So what happens, it's unfortunately on very individual level. So sometimes women can go through the menopause and not experience any vasomotor symptoms, no hot flashes, no night sweats, no insomnia. They have different mild symptoms, but not really something that's debilitating or reducing the quality of their life. However, some women can have debilitating symptoms that can last for a very, very long time, and those need to be adequately managed. But also, what we do as health professionals and as part of the menopause clinic, we do a lot of health promotion. We advise on healthy nutrition, healthy lifestyle, reducing alcohol, reducing weight, and becoming more towards within the 25 body mass index, weight-bearing exercise, because the healthy nutrition and exercise with weight and resistant training is the cornerstone of a very healthy menopause. And as women, we need to be consciously putting effort and action towards eating healthier, sleeping better, exercising, and trying to increase our protein intake and trying to increase our muscle mass. Because the more muscle mass we have, we gain, the healthier we are going to be in the long run. The more we are able to reduce our body mass index, the healthier we are going to be in the long run. The more conscious we are of all of the things that are out there, not just only HRT, but any other things that are out there that is health promotion and healthy living lifestyle, the more we are in control to make the necessary changes to have a healthier and good menopause. But the symptoms from one individual to the next individual can vary very dramatically. So some people can have symptoms sadly even in their 70s, even in their 80s. So it's very individual on individual basis. Yes, please could you show the help websites again? Please, everybody, just if you can, if you're able to go onto our Rosie website, Rosie Hospital website, and there is like menopause, perimenopause and menopause section of the web pages with a lot of resources, a lot of information for women. And just know that we're also here, occupational health and our menopause service in-house, and we're able to support everybody on individual basis and provide advice, help and guidance and support. Right, thank you. Oh, you're very welcome. Thank you. That is very informative answer. That is reassuring. Is the oral estrogen always required, or is the coil alone sometimes enough? Estrogen hasn't been mentioned as yet by my GP, just the coil. I'm 42 years old. Symptoms are not related to bleeding, but more other issues related to hormone fluctuations around my period, example migraines, very sick stomach, and etc. So oral estrogen, it's we're trying to move away from the oral estrogen. We are trying to go more with the transdermal route, which is much better and reduces the risk of deep vein thrombosis. But I would push for your GP to actually run some basic blood tests just to ascertain what is happening. And if you just relay the symptoms to them, they will be able to help. So having the Mirena coil is good. And in terms of easing any like really heavier bleeds or very difficult menstrual cycles and fluctuating cycles, and is also very good contraceptive below the age of 51, 52. But we can see through the blood work and the blood tests what is needed. And if you're really low on estrogen, and if you actually have the menopausal symptoms, they can introduce transdermally just a very low dose of estrogen just to titrate. But migraines and like stomach issues or disturbances or nausea or not feeling right, particularly around the time of the menses, could not well be related to the perimenopause. We just need to have like a bit more of a broader assessment of what is going on in terms of your individual needs. So I would advise to go back to the GP and ask for a little bit more in-depth, thorough assessment and some blood work. Suffering from weight gain, brain fog, insomnia, anxiety, exhausted, and cholesterol results a lot higher. So again, I will go back to your GP and I will ask to be properly assessed and properly checked, and all of the blood work, like as part of your health check, to be done, and then have a conversation in terms of HRT and your particular symptoms of the menopause. Again, I don't know your age, so I can't kind of roughly guess where you are in your journey. So I would ask you to just seek advice from your GP. They should be able to advise you in terms of the HRT, and there are many, many different preparations of HRT that can be used even in perimenopause, or assessment to be done and see what is happening. But with the cholesterol, partly is our lifestyle choices and our diet, but with the high cholesterol levels, it can be genetic. So we are genetically predispositioned to have high cholesterol levels. But if we can strive to try to balance healthy nutrition and healthy lifestyle, we can have an impact on cholesterol levels ourselves. And then, if we've done what's absolutely within our control and our power to be healthier and implement different things in our diet and exercise, then we can still go back to the GP and say, and it will be even furthermore beneficial, because you can go to the GP and say, okay, I've done this, I've done this, I've done this, but this is what I'm dealing with. These are my problems. These are my issues. How can I actually get a little bit more help and support? And is HRT going to be beneficial for me in order to regain a little bit more better quality of my life? Thank you very much for all your very helpful and advice. Like, you're very welcome. It's a pleasure. It's a pleasure to be helpful and give all this information to you. You're very welcome. Any questions? Any other questions? More than welcome. I I hope I have covered enough, and I hope I have given enough advice and information as tools for you to be aware of, or even like a little seed of knowledge that I've parted on to you, in order to go out there and do a lot of your own research, look at the websites. As I said, British Menopause Society has got amazing like resources. If you go also on Menopause Matters, they've got loads of different things, including diet, including other different ways of managing and coping during perimenopause and menopause. And just before everybody goes, just to mention, CBT is proven to actually be very helpful when dealing with vasomotor symptoms of the menopause. And in our region, we can self-refer for CBT. So if you go on Google and just put CBT self-referral, you can actually go to the appropriate link and click, and you can refer yourselves for CBT. And that can be very helpful when dealing with the vasomotor symptoms like the hot flashes, the night sweats. It's proven scientifically that it works. Yes, yes, the recording will be circulated and shared. And I'm actually a bit nervous about it all, because this is my first public kind of speech and presentation, and I don't know how well I've parted my knowledge and experience onto you guys, but I hope that you got what you wanted to hear and what you desired to actually achieve and learn and listen to. And I hope I made it a little bit entertaining with the little comedy slides on the PowerPoint. Thank you. Thank you. It means a lot. Thank you. Thank you. Thank you very much. It means a lot to me. And as you can see, I feel very passionate about the menopause and passionate about helping women. and trying to do what's best for everybody and give the appropriate advice. So, like I said, information is everything. So you need to power yourself up with a lot of information, do your own little researches, look at the relevant websites, because once you've got all of the information, you can then make informed choices that are directly going to affect the quality of your life and also ease the symptoms of the menopause or the perimenopause, because everything is within your control. And just attending again with your general practitioners in the primary care, discussing in depth about the symptoms you're experiencing, asking for a health check, blood tests, asking more questions, being a bit more proactive, and saying, okay, I would like to try, I would like to know, I would like to see what's out there that can help me and transition me like through this very complex period of our life into a very nice balanced way that I can actually feel well in myself and then be able even to do even more like health changes that are beneficial for my own unique health and life. Oh, you're very welcome. You're very welcome. I'm just reading the thank yous, and it warms my heart. Thank you so much. Wow, thank you. I'm like really honored. And maybe we can be doing a little bit more of these sessions, or maybe, I don't know, maybe we can establish once a month, like a little Teams group meeting where people can feel free to ask questions and get the advice and support. And I just wanted to say to everybody, I'm here for each and everybody, and each and every one of you to support you and guide you, and just like send me an email, give me a message. I'm here. Yes, another person he said, I think more sessions, a group would be fantastic. Some of my colleagues couldn't come today and would love to attend another session. Yes, we can have like a monthly sessions where we all log in, and then I can share loads more information, loads more conversations, what is relevant, what is the latest research, because there is so much to be said when we're talking about menopause and perimenopause. And there are so many studies, so many wonderful articles, and especially with the British Menopause Society that governs us, is absolutely wonderful to be able to impart all of these things in a group session like this, and then be able like to talk and educate and spread the health promotion, and but also allow people for like questions and receiving the answers and getting what they need, so they can then go to their respective GPs, and or even go home and think about it and see what kind of like things they can implement in their own life. Thank you. Thank you. Anybody having any other question or anything else that I could cover in the next 5-10 minutes? I don't know how long we've got left. I definitely think it will be beneficial to have like group sessions and like run something like once a month. Oh, thank you. Thank you.